I'm here to present a simple sepsis screening tool. I reviewed a research article that was based on a nurse-driven sepsis screening tool that would be used bedside when nurses did their assessment with the intent of early identification, physician notification, and improving patient outcomes. Sepsis remains the sixth leading cause of hospitalization, which highlights the need for an early identification tool for nurses. Early identification with timely implementation of goal-driven therapy will decrease sepsis-related mortality and increase cost effectiveness of treatment. Evidence indicates patients diagnosed with severe sepsis during inpatient hospitalizations are twice as likely to die as those diagnosed in the ER. The purpose of this study was to examine the effectiveness of a nurse-driven bedside sepsis screening tool in an intermediate unit full of medical and surgical patients. The interesting thing about this particular study is that the majority of studies done on sepsis screening tools that actually evaluate the tool are based in ICUs and ERs. This is the first study of its kind based in an intermediate unit. The Simple Sepsis Screening Tool is a three-tier model designed to measure a predetermined set of vitals. And in this study, that was my objective data. This particular tool in Tier 2 allows the nurse to use his or her nursing judgment, which then becomes the subjective data. It also establishes a clear pathway for the next steps based on the result of each sepsis screen. This slide is actually the sepsis screening tool that was used in this research study. It was a paper tool that would be taken in bedside when the nurse did his or her assessment. A screening tool used as a decision support mechanism for early identification of sepsis has been widely advocated. However, studies validating the necessity of this tool are scarce, especially in non-ICU settings. This particular study didn't pose a research question, so I evaluated all of the material and made up my own research question based on everything that the researchers discussed and talked about. Will a simple nurse-driven bedside screening tool using predetermined vital measurements and nursing judgment improve early recognition of sepsis, physician notification, treatment time, and ultimately patient outcome? The method was that RNs using this sepsis screening tool on consecutive patients admitted to this intermediate unit. And the patients that are screened Q8 every 8 hours, and those with a positive screen had their primary care team notified, and the subsequent actions of the primary care team were recorded. This nurse-driven tool is a simplified version of the Severe Sepsis Campaign screening tool. It's a paper-based tool designed to be used by the RN during the regular patient assessment. The measurement criteria to be documented was a heart rate greater than 90 is a positive screen, a white blood cell count greater than 12,000 or less than 4,000, a temperature greater than 38 or less than 36 degrees Celsius, a respiratory rate greater than 20, or a PaCO2 less than 32. This study is an observational pilot study with a retrospective assessment of patient clinical data. I used the CASP Cohort Tool 2018 to evaluate the validity of this study. Researchers in this study received a Notice of Determination Waived Review for this study because it was a quality improvement project. The research design, Tier 1, evaluates a predetermined set of vital signs. If the score is less than 2 positive screens, then it's negative and the screen is complete. If the score results in greater than 2 or equal to 2, the RN will then know that they need to proceed to Tier 2. On Tier 2, the RN will evaluate for possible infection or a source of infection. If the infection is ruled out, the screen is complete. If infection is suspected, the RN will proceed to Tier 3. In Tier 3, the RN will evaluate the patient for organ dysfunction, document it, and notify the physician. According to Guyang et al., 2015, the results of the screening tests were then compared to Patient International Classification of Diseases, 9th revision. It's called the ICD-9 codes for sepsis. Severe sepsis and sepsis shock identified during the same period, and performance of the screening tests were all assessed. Patients with a positive sepsis screen were followed, and all testing and subsequent care was documented in the patient chart. Results. 245 consecutive patients admitted to this unit were all screened. 2,143 sepsis screens were performed during this time. 169 of them were surgical, 76 of them were medical. This screening resulted in a 9% overall incidence of identified sepsis. 8.9 of them were surgical, 9.2 were medical. The simple screening tool was shown to have a 95.5% sensitivity and a 91.9% specificity, and no performance variation was noted between the identification in surgical or medical patients. So, 245 patients, the confirmation of sepsis was 9%. 39 patients screened positive. 51% were positive for sepsis and 49% were positive for severe sepsis. The positive predictive value was measured at 70% in medical patients and 48% in surgical patients. Accuracy of this screening tool for both surgical and medical patients was 92%. Limitations of this study. First of all, the study was limited because it was only done in one intermediate unit with a small sample of 245 patients. The duration of the study was short. They performed this study for 1 month. The retrospective analysis inhibits the researchers from gaining the total picture of the patient's health. Medical surgical patients can exhibit post-op symptoms of fever and tachycardia, which can present as sepsis, which in fact it might be a non-infectious process. The CASP cohort tool that was used helped me to determine that this study presents clearly defined subjects of focus. No evidence of bias was noted because the patients were admitted to the study on a consecutive basis. Objective data recorded was the vitals. The subjective data recorded was the nursing judgment. In conclusion, as evidenced by this study, a positive sepsis screen followed by documentation and physician notification may lead to an increase in timely, goal-driven sepsis interventions for medical and surgical patients. Although this study is small and limited, the results imply that there is significant value added with regular bedside sepsis screening, this tool that was decision-driven. There is not enough evidence, by my estimation, in this Level 4 study to implement a change in our overall nursing practice. However, there is validity here, which warrants, I believe, further investigation. I would like to see more studies with the same design performed in multiple intermediate units to see if nurses as the first line of defense and the first line for early identification can actually have an impact on treatment and ultimately patient outcomes, which is what we really want. Thank you.